Yes, that will be my first question. We would like to ask your permission to record this webinar. So if you don't want to be seen on the video, just feel free to turn off the camera. Welcome to this webinar. My name is Monia Ebersold. I am an MHPSS program manager at the Swiss Red Cross, and I'm co-leading this Red Cross and Red Crescent research network, MHPSS research network, with the wonderful Sarah Davidson, head of Psychosocial and Mental Health from the British Red Cross, who cannot join us today, unfortunately, but it's my pleasure to facilitate this webinar today. Before we start, let me briefly introduce you to this network. It was founded in June 2016, and this network is actually born from the powerful vision to strengthen humanitarian action through evidence-based mental health and psychosocial support for the people we serve, our beneficiaries, but also for our volunteers and staff. And at its core, this network is actually a dynamic space for collaboration and shared learning, uniting MHPSS researchers and practitioners across the Red Cross and Red Crescent movement. It's a place where science meets practice to create lasting impact. So how does this research network make a difference? And there I would like to highlight especially 3 key activities. There are our quarterly newsletters, and these updates bring you the latest in global mental health research, upcoming events, and funding opportunities. So it's your go-to resource for staying informed. Then we do host webinars like the one today for learning and sharing. And through these webinars, we learn directly from those on the front lines of MHPSS research. And these webinars showcase also best practices and lessons learned from real-world experiences. This is the 3rd webinar in a series this year. We were already talking about mental health and psychosocial support and climate change and digital MHPSS. And we also, thirdly, we also create spaces where researchers and practitioners come together to share findings, exchange ideas, and form partnerships. So collaboration is actually at the heart of what we do. So please, if you're interested, join our network. I will put all the information around the network in the link so that you know how to find us. And now, what can you expect from this webinar in the next 60 minutes? We do have 3 speakers here with us today, sharing their learnings and experiences with us on the integration of MHPSS across sectors. And there's also space for Q&A and for discussion at the end of the webinar. So if you have any technical questions to the speakers, you can put them in the chat and we ask them immediately after their presentations. But hopefully there's also going to be some time at the end of the webinar for discussions. Keep an eye on the chat also during the webinar because we will put interesting resources there for you. So make sure you don't miss them. All right, so let's dive into the topic. In today's webinar, we focus on one of the key missions of the International Red Cross and Red Crescent movement since the adoption of the MHPSS resolution and policy in 2019. It's about the integration of MHPSS into humanitarian services, I already mentioned. This mission is about embedding MHPSS across sectors, making it a core element of our DNA and of our way how we serve communities in need. Now, Shona Whitton, who's here with us today from the IFRC PS Center, and Sarah Davidson from the British Red Cross are supporting this critical initiative. They are co-leads of an MHPSS Roadmap working group supporting movement components in bringing MHPSS into every corner of their work. Together with their working group colleagues, they have consulted practitioners from national societies, the IFRC and the ICRC, about their achievements and the barriers they encountered when trying to integrate MHPSS into their different operations. So today is about more than theory. We're here to learn from the experiences of 2 national societies from the African continent that participated in this consultation project. It's 2 different case studies, one from an epidemic and one from an emergency response setting. So without further ado, let's dive into the topic, and I hand over the floor to you, Shona, for a short presentation of this consultation process. Let me quickly introduce you. Shona is a technical advisor in mental health and psychosocial support at the IFRC Peers Center. She's specializing in MHPSS in emergencies, climate change, and PGI. And prior to joining the IFRC, Shona worked in emergency operations with the Australian Red Cross, and she's actually joining us right now from Australia. Shona holds a bachelor in psychology and a master's in community development and so many more diplomas. So please, Shona, tell us more about this consultation project.
Thanks, Monia. I'm just going to quickly share my screen so I can show you the report, the cover of the report that I'll talk a little bit more about later. But yes, so Working Group 1 has been working away looking at integration of MHPSS in the movement, mapping of basic psychosocial support activities, and also around planning and assessment for MHPSS since we formed in early 2020. And at the beginning of this year, the group was thinking about, for our kind of last year in together, what would be a sort of impactful piece of work for us to work on. And one of the things that we felt was sort of lacking in the movement was a documentation of how integration is going. We wanted to really ask our colleagues in MHPSS programs in national societies, the ICRC and IFRC, what is it they're doing? What are their successes? What are their challenges? And so that led to this consultation project that we started earlier on in the year. So our working group members supported the co-leads, Sarah and myself, and we also had a great support from British Red Cross, some admin support on this project from Alex to conduct semi-structured interviews, some focus groups, which Ernest and Sarah were part of, and you'll hear more about their work soon, and also developed an online form to collect examples of MHPSS integration. So we, some of our working group members interviewed each other. I interviewed some people, I conducted some focus groups, and we also had a number of interviews from some colleagues in languages other than English, which was really useful for this piece of work also. So all told, after all of that work, we had 35 participants from all components of the movement. Our largest representation was people working in the African region, which we were really happy about, and was really down to Guled and the brilliant Anglophone African community of practice that gave us their time. And it was great to have representation from a region other than Europe. So often we see lots of representation from European context in some of these types of reports. So we were really happy about that. We also, as part of the consultation, we collected examples of MHPSS integration. So this was through an online form, which we shared on LinkedIn and through many working group meetings to ask people working in national societies and IFRC and ICRC to say, what is it that you do? Like, what are examples of integration in your work? And that was really useful because we did want to discuss the barriers and the challenges and the successes, but we also wanted to document what's happening. So the report, which you can see the cover of here, has two parts of it. And towards the end of the webinar, I'll talk more about the outcomes from the consultation. But the first half of the report covers the consultation project, the methodology and the findings. But then the second part is case studies from a range of different national societies, the ICRC and IFRC, in how they're going about integrating MHPSS. So we really feel that this is a useful tool for all of us working in MHPSS to share internally with our colleagues, our leadership potentially. And we were lucky enough to have some hard copies when we went to the international conference in October, and we didn't come back with any of them to Copenhagen. So hopefully it's out there being read and used. So Monia, maybe I'll now hand over back to you for our other speakers, and then I can come back with some examples at the end.
Yes.
And the themes.
Thank you, Shona, for this short introduction. I'm happy to introduce you to our next speaker then, who is going to inspire us with his insights from a case study from the Ghana Red Cross Society on first aid and psychological first aid at workplace. Welcome to you, Ernest Nyamiaman, coordinator for MHPSS and first aid with a wealthy expertise in public health and training. I hand over to you.
Thank you very much for the opportunity. Please, can we all see it? Okay.
Yes, we can.
All right. Thank you so much. Our main topic within the Ghana is to integrate the mental health and psychosocial support activities in our core programs. And that is what exactly we are doing currently. And I want to share what we do in just within these few minutes. And as you know, the theme is integration of mental health and psychosocial support in Red Cross movement. So we are within it. Now, my outline, I want to just give a big background of Ghana Red Cross, and then the activities, and then the challenges and the recommendations. So just a straightforward thing. The background, I'll just make it brief. Ghana Red Cross Society was formed way back 1929. And it started as a maternal and child welfare, League of Maternal and Child Welfare. And then later, the parliament passed the support to establish the Red Cross. We have 16 regions. In these 16 regions, we are operating in 10, but then the other region, they are having oversight supervision of other 6 regions. So it is not that we don't have physical offices in 6 regions, but it was created some 5 years ago, and we've not been able to get it. We have over 170 districts, and we are working with 60 volunteers across the country, 60 volunteers. Our main programs is the first aid, health and social care, and disaster preparedness, and then response. So what I want to share is what we did during the COVID time with a collaborative effort. And then when there was a flood in some part of Ghana, what we also did with mental health and psychosocial support thing, MHPPS, and then first aid. So with COVID, during the COVID, we collaborated with Hope for Future Generation, and then the young people advocating for Ghana, and then the NAPLAS. NAPLAS they are working with the people living with HIVs, because that collaboration was to encourage people living with HIVs and then the general public to actually take the vaccine, because they have a lot of misinformation and disinformation about the COVID vaccine. So we have to train our volunteers and then let them know how to handle something to them, because already there's a fear. So how do we let these people take away that fear from themselves and then that anxiety? So we train our volunteers on mental health and psychosocial support and other things so that we get into the community. The main aim is the goal is to reduce the hesitancy level. And I remember those days, Glade help us with material presentations. So that will actually guide us with the training. And it was very, very well. Our target, in fact, we reached our target we exceeded our target. So for people living with HIVs and then with the general public, these were the 2 key areas that we do. Whilst Ghana Red Cross Society is working with the general public, the other partner, that's people living with HIVs association, they were also focusing on people working with HIVs. And you can tell from the target. Red Cross, our target was to reach 1,200. And you can see that we're able to reach over 12,000 people. And it's because of the method we adopted. So we went to marketplaces where people are gathered. We went to churches. We went to mosque to advise people, educate people that they shouldn't fear about the vaccine. Vaccine is okay, because there's a lot of fear. And people will tell you so many myths that if they use, if you get a vaccine, if they put your phone on where the vaccine is, it will stick there. And then we also show them that it is not, to the point that people think that when you get the vaccine, you'll be impotent. And I told them that I'm not impotent. I'm still firing, excuse me to say. And that alone share the love, because we share our experience to them. And we're able to reach this great number of people. So we were able to reach 12,000, and then out of the 12,000 people, 5,846 people accepted, and then the people who took the vaccine were 2,277. And we're able to reach this number of people with the training that we give our volunteers. So this is still the sum up of what we did, the statistics, the number of people reached, the number of people accepted, and then the number of people who actually vaccinated. So this, we started from June, July, and August. So it was a 3 months project, and it was supported by UNAIDS. It was supported by UNAIDS to actually carry on this project. So that one is the project. So this is the picture when we were launching the program. I was the MC for the day. So you can see my traditional coat on me. And then we have all the partners, with even the government present, the Ghana Health Service, they were present, and all the partners. So these are the activities. The first picture on the left is when we're having the training, the mental health and psychosocial support for the people. Then the rest are when they went to town. So you see somebody, a lady standing in front of the people in the mosque, and somebody in the church, and then somebody also at the marketplace trying to educate people on this. So that one is for the COVID. And then for first aid, we realized that psychological first aid is very key. So in all my first aid training, currently I'm the coordinator for first aid in my national society. So all the training, we now put the psychological first aid. And it's amazing how the participants are embracing psychological first aid in this training. So, and most of the time, what we do, the trainers, we try to open up, and then they share their experience where they've been helped before when they were in distress, and then where they have also helped people before when the people were in distress. And it's amazing how people are finding a lot of challenges. And these are some of the words that dropped from them. Seeing ourselves as a team, that is after the psychological first aid, they see themselves that, no, we have to work together. We should be each other's keeper. We should have a sound mind for people. We should be courageous in everything that we do. We should be able to get this. We should not carry the burden. Let's try to drop the burden. We should care for one another. And then we need each other in this. And to the point that some of the companies are thinking that they need to have even a unit to handle psychological issues. And for me, I think it's a plus for Red Cross pushing this agenda, and the companies are actually getting to embrace it. I think it's a very good thing that we need to actually keep on pressing on it. The challenges, the key challenge of course, in every project is funding. So you can see the coins there. So I think we need funding support for our mental health and psychosocial support. We lack funding. So though we are trying to mainstream with other activities, sometimes it also compete with their budget. So they say, oh, we have this budget for this, we don't have budget for psychosocial support. Then it makes your effort very, very, very frustrating that you want this to be done. The project officers, the budget holders, they are giving you these challenges. And for me, it's a very good. So our recommendation, one, we need to sensitize the leadership of the national society to understand the importance of psychosocial support in everything that we do. Because if they don't understand, like the governance, the management level, even the officers, they need to understand this point. I was happy, I think Africa region, they sent a message after the international meeting that mental health and psychosocial support is very key. So they sent to all our national society, and my president and then my secretary general also received it, and then he acknowledged it. So I went to him and I said, yes, we'll just be trying to push the agenda. So I think when it is also coming from the top, and then we are down there, we are also doing our bit, we'll try to get to a sound place. So, I mean, trying to train the volunteers and the staff and all these things. And then the regions should allocate adequate funding. I think it's the same thing. And then my concluding statement is I have just 2 minutes to finish. Yes, my concluding statement is very simple. All must be on board to create an enabling environment for mental health and mental health activities across the globe. Yes, mental health and psychosocial support is a human rights thing, and we need to act now. All must be on board. Thank you so much for the time. Thank you so much.
Thank you so much, Ernest, for these insights and for sharing your experiences with us. Is there any urgent questions to Ernest for now? If not, there is still a possibility later on. I'm not sure if I see everyone. I don't see any hands up, so please, if there's any questions, keep them for later. There's still opportunities. So then let's move on to our next speaker, who is giving us insights into a case study of the Zambia Red Cross Society about integrating MHPSS in an epidemic response and addressing MHPS needs during public health crisis. I hand over to you, Sarah. Just a quick introduction. Sarah Kalumbilo is an experienced health and social work professional with over 15 years in project management, MHPSS, and community engagement. And as a health promotion officer, she has led responses to major public health emergencies, including COVID, cholera, and droughts, incorporating MHPSS and risk communication into health initiatives. Sarah holds a Bachelor of Social Work as well as several diplomas in project management, community engagement, and gender-based violence management. Welcome to you, Sarah. Hand over.
Thank you. Thank you. Good morning to everyone. I hope you are able to see me.
Yes, please. Beautiful.
Thank you. Thank you. Yeah, so before I start, I just want to pay special recognition to the Director of Programs from Zambia Red Cross Society, Mr. Jack Babu, who has joined the call, and also the Health and Care Manager, Madam Ruth Asayele, that have joined the webinar. So thank you so much for sparing time to join in. Yeah, so I'll quickly jump into it. And of course, I think I'm going to write on the recommendations that Ghana Red Cross Society has alluded to in their final slide. And I think this is what I'm going to speak to. So as you can see, I'll be focusing on integrating MHPSS in epidemic response, a case study of Zambia Red Cross Society. Yeah, so we can proceed. So if you look at the first slide, sorry, you may move my slide. Yeah, so if you look at the first slide, I think everything that we are doing as a national society, let me be quick to mention that we are present in 10 provinces of our country. And in our country, we have 116 districts. And as a national society, we are present in 53 districts with over 7,000 volunteers on the ground who respond to a number of disasters. So in line with the integration of MHPSS in the national society, I must say that everything that we are doing is as a result of the COVID-19 pandemic, which saw a transformative period for the organization, like ourselves being Zambia Red Cross Society, because then the COVID-19 did expose a number of vulnerabilities in public health systems, including mental health gaps. So just like a partner to the government authorities, we too, as a national society, did deploy a number of volunteers on the ground to address physical needs. And it was at that time that they encountered a widespread, so to say, psychosocial issues, including stress, anxiety, and stigma. So the situation really underscored the importance of a more holistic response to crisis. Because then we needed also to address emotional, psychological, and well-being alongside the physical health. As we know, there's no health really without mental health. So this called for a significant, change in reevaluating the response mechanisms of the national society to incorporate, mental health and other cross-cutting issues such as CEA and the PGI. So recognizing the significance of the mental health, during the pandemic, Zambia Red Cross Society had then to make strategic decisions to formally integrate the MHPSS. And this saw us, including the MHPSS in line with particularly focusing on psychological first aid, which was to better, support affected individuals and communities. So for us, really, this shift reflected a much broader understanding that addressing mental health was more essential for sustainable recovery, so to say, and the community well-being. So everything that we are doing in line with MHPSS, was best from the COVID-19 era. We can proceed to the next one. Thank you. So I always like to highlight this particular concept. If you see this, that we can just click so that we can see a lot of the psychological. So this, what I'm showing you is behind the mask. This is a concept that has been driving MHPSS in the national society. We saw during the COVID-19 that, even if people were wearing all those masks, but behind the masks, there were all those psychological traumas, the worries, the stress, the distress, and many other things that the naked eye could not see. And so it could only be seen by someone who was trained. And in this case, it's the volunteers that we had deployed. So we saw that it was not just the physical needs, but we also had all these psychological, needs. We can proceed. So this is a concept that was derived, and all thanks to my colleague, Stephen Poso, of course, who helped to come up with this wonderful concept that is driving our work currently. So why did we integrate MHPSS as a core component for the national society? And it's just for a simple reason that we as a national society, of course, we always want to address emotional and mental well-being. We've integrated our MHPSS in all our responses. I'll speak to the responses in a little while so that you can see which responses we are currently responding to and those that we have responded to. So we always want to address emotional and social well-being. So we acknowledge that crises such as epidemics and disasters always leave individuals grappling with trauma, stress, and anxiety. So when we integrate MHPSS, we just ensure that our affected individuals receive the emotional and psychological support they need to navigate all these challenges. And another reason is that we want to promote resilience, very key. Resilience is key after a disaster, during a disaster. So MHPSS for us plays a critical role in the recovery. It helps individuals and communities rebuild their mental strength. Why? I've said it. The volunteers go on the ground. We have integrated PFA with other core elements during the trainings. Before volunteers go, we engage them in a number of trainings, starting with risk communication and community engagement. We have community engagement and accountability. We have protection, gender, and inclusion. We have many other trainings, but core key is also the integration of the psychological first aid skills that they go with in the communities. Another reason also why we've integrated MHPSS in our epidemic response is also to reduce the issues of stigma. for every pandemic or disaster that strikes, there's always issues of stigma. And so with our volunteers, because we have equipped them with all the skills, they're able to encourage open conversations about mental health, also breaking down barriers of shame or even discrimination. And in so doing, we are normalizing, discussions around mental health at household level, even at community level. Yeah, we can move. But of course, as I move on also, and yeah, we can move to the next slide. Thank you. So in our strategic approach, and I think this, I'm going to draw maybe one or two questions. So we can just go back a bit. In our strategic approach, we have engaged for us to be able to integrate MHPSS in the epidemic response. It all started with someone and from somewhere. Like I said, from somewhere during COVID-19. First and foremost, as a national society, and I think Ghana is really keen at listening to this because these were their recommendations. So we had to start from somewhere, and that, yeah, so the National Society needed a dedicated MHPSS focal point person, who happens to be myself. So I had to drive the coordination, the training and advocacy for the psychosocial support within the organization. That was number one strategic approach. The second strategic approach was the senior management buy-in. Very, very important. Gaining support from senior leadership. It helped MHPSS to be recognized as a critical component of a disaster. And I say so because it was targeted. When I came in, I had to target management first. They also had to undergo a training in psychological first aid for them to appreciate what was to come in line with MHPSS. And then thereafter, it was easy for us to include in the budgets and the proposals. Systematically, it was embedded in all the epidemic and project proposals. So every time we have an outbreak, it's very easy because management knows, and they know the importance of MHPSS. So in all our proposals, strategic documents, it's embedded as one of the core components of the response. And again, and I think what also helps is in integrating MHPSS is a multi-sectoral and collaboration with key partners. Key partners, I'm talking about national level. At national level, we have the Zambia National Public Health Institute, who we are working closely with, together with the Ministry of Health. And this has also really helped us because as a national society, we are a member of the National Technical Working Group. So it's easy for us to spread our wings even when we are responding to a disaster. We bring our efforts together with other partners. So we got buy-in from the national level as well. Holistic strategy, yes, MHPSS is integrated, like I said, with other core interventions. The WASH, the water hygiene and sanitation, the health promotion risk communication. This is integrated. So such initiatives really, and we found ourselves participating in symposium at national level. So this has fostered the knowledge sharing and advocacy, thereby making it easy for the national society really to embed the MHPSS. We proceed. Yeah, so the key elements that are drawn from the MHPSS strategy, basically, we can proceed, is the integration of MHPSS into emergency response, like I've said. So we have recognized as a national society that it is very essential to comprehend, we have recognized that mental health first and foremost is very essential to comprehensive health responses. So embedding it really alongside other physical initiatives is a plus. And the more you scale up, it also helps us to remain a priority in all our emergency responses. Because most recently we were battling with cholera outbreak in Zambia. And I must say that as a national society, we were the first ones to incorporate the mental health and psychosocial support in their response. So that earned us that good, a level where we are as a national society, because then we are known that we are not just responding to the physical needs that other partners are, but we have also, engaged in responding to their psychological needs. So I also drew up something from there. As you can see, that's just a picture. During the COVID-19, we were able as well to reach out to the healthcare workers, and because we wanted them, because these were the frontline workers, all we wanted was to equip them with psychological first aid so that they could continue remaining resilient and thereby helping the many patients that were in the health facilities. So that is just a picture. And it also reduced the isolation effects and increased the resilience. So yeah, we proceed. That was just an example of the mental health response where we integrated the MHPSS. And what we can see there also is the capacity building. Capacity building, very, very important. On this one, our training usually focuses on psychological first aid, community engagement, and psychosocial support to equip the frontline responders, our volunteers, ourselves as officers. In earnest, you are also a frontline responder. Very, very important. All responders have to be equipped with psychological first aid. And this is our training focus as a national society. We also empower staff and volunteers. We conduct extensive training sessions for staff and volunteers in MHPSS, different methodologies. And this has enhanced the national society's ability to deliver mental health and psychosocial support in emergencies, even post-crisis recovery. Right now, as a nation, as a country, we're in the post-crisis cholera recovery, but our volunteers are still there on the ground, conducting risk communication, community engagement, which we embedded the psychological first aid. We've also gone ahead, like I mentioned, I think the partnerships to standardize in interventions. We've collaborated very, very well with the ministries of health, and I mentioned the partners. So the partnership has ensured consistency, so to say, and quality and cultural appropriateness in MHPSS service delivery. And our goal, basically, even as we engage in such partnership, is just to build capacity, which aims at sustainable MHPSS support. So in the picture there, you can see some of the trainings that we have had with the healthcare workers, and also even the project staff on different responses. Thank you. We proceed. So we also have, I also decided to pick out something from the strategic approach, which was the community engagement that I have mentioned. As you can see in the picture there, that is the ZNPH, that is a national MHPSS focal point person from Zambia National Public Health Institute. Because we work closely with the national level, it's very easy for them to support us during major outbreaks. This is the cholera outbreak. So they had to come down to help us to roll out the psychological first aid in line with what they are doing as a nation. So this also has been very, very effective, because combined mental health with risk communication to tackle misinformation reduces stigma, thereby promotes mental, emotional well-being during crisis event. Of course, I'm not going to rule out the issue of feedback mechanism. We've established as a national society platforms like community information desks and feedback during, channels to ensure community voices were heard and active support. So with us, we've also engaged massively in community mobilization campaigns where we've embedded the issues of, curtailing where we've conducted anti-stigma campaigns to address harmful misinformation about mental health. All this is because volunteers are appreciating the skills that they've received, and they are there on the ground. So they get to really know what is happening, and we're able to respond accordingly. So as I proceed, I'm almost finishing. We can go to the next slide. So in terms of the MHPSS interventions in the crisis response, we have seen as a national society, we have responded to cholera response. Like I said, this was really, we had a lot of cases and we had to move in swiftly. It saw one of our major football stadiums being turned into a cholera treatment center, and we had to move in with our volunteers trained in psychological first aid just to set up a psychosocial support tent where volunteers were trained and they were deployed to offer the psychosocial support. So these are some of the interventions, these are some of the crises, let me say the epidemics that we've responded to. Cholera response, we've embedded it in the COVID-19 response. We've also integrated it in GBV support under the Help the Helpers project, which was focused on COVID-19. Even in the Orphans and Vulnerable Children project, we've also integrated MHPSS. Anthrax response, we've also integrated. And above all, I would want to point out this self-care. In everything that we are doing, let's remember that these are epidemics, and there's a bit of burnout in some of the volunteers and the staff. So we take care of our staff very, very well, and volunteers. For we introduce and we run self-care activities throughout the response. So these regular activities are designed to promote mental health and reduce burnout of the staff and the few teams. We can proceed. So some of the current response that we are engaged in as a national society at the moment is a drought response, like I have I've mentioned. And in here again, we have deployed a lot of volunteers on the ground, and we have equipped them with we've equipped them with psychological first aid skill. Those are just wonderful pictures of the self-care activities that we do. You can see I'm actually enjoying a meal there during lunchtime break, where we work closely with our partners while it's giving a talk on remaining resilient as a field staff. And then, we have outdoor events for our volunteers throughout. Yes, thank you. I have a minute. I'll be wrapping up. We proceed. What are the challenges? Challenges are always there. Like Ghana Red Cross as well has alluded to a number of challenges. We can proceed. Challenges are always there. Oh, maybe before I get to challenges, I want to show this previous slide. I just want to show people that have joined in that in terms of network, and I think this is what also drives us. Thank you to IFRC Psychosocial Support Center, Bullet. We have been in touch as a Southern African region where we share these best practices. So you can see that we're a member of the global cluster, and these meetings are held monthly where we get to share how we respond to different disasters. Thank you. So in terms of challenges, we too have challenges as a national society. I think limited resources, insufficient funding to establish a dedicated budget for MHPSS has continued to prove as a challenge. And of course, coordination and collaboration gaps with other partners. Of course, there's very poor coordination between partners and stakeholders, even fragmented implementation leading to duplication or even sometimes unmet needs. So those are some of the challenges that we have. We proceed. Yeah. So in terms of challenges, of course, I may have one or two solutions. It's just to advocate for a dedicated MHPSS funding to increase, so that we are able to increase awareness and advocacy efforts to ensure that MHPSS receives its own budget allocation. And then also another solution would be to strengthen coordination and also train more MHPSS professionals within the national society and promote mental health awareness to, of course, to continue reducing issues of stigma. The last slide, just photos that we have there. This last slide as I conclude. Yeah, so those are just pictures of our works that we have done. We do conduct outdoor psychosocial support initiatives in the communities. That was the psychological first aid training that we did with the children during COVID-19. Those are just wonderful pictures. Thank you. We proceed. I think I am done. Thank you so very much for listening, and we open it up to questions. Thank you so much.
Thank you so much, Sarah, for these rich insights into your work. And without losing any time, we keep the questions for the end. I hand over back to you, Shona, for some key conclusions and recommendations from the consultation project on how we best integrate MHPSS across sectors.
Yes. Thanks, Monia. Just move back to my, so this is just all these slideshows today. Yes, so I think what's interesting is a couple of the things, well, many of the things that both Ernest and Sarah shared came out in the report as well, as challenges or barriers. And so I just want to cover off, there's 5 sort of overarching key themes that came out of the consultation. So this is a reminder to back at the beginning when we were discussing who was involved. So we had all components of the movement, and we did a thematic analysis of the transcripts of interviews and focus groups to determine what the kind of key themes that people discussed. So a number of things came out around barriers to MHPSS integration. And in particular, it was that often MHPSS activities and services are not prioritised within both national societies, IFRC and ICRC. And, you know, in some cases is because of a lack of resourcing, both human and financial, or, you know, very much, I think, as Ernest mentioned, competing priorities. Lots of participants talked about in general, there's kind of a desire for the National Society, for example, to engage in MHPSS, but other programs just maybe there's government contracts or for those programs, or there's other priorities above MHPSS. So this really came through as a real challenge. And also still this these misconceptions around what MHPSS programming actually is. I think this has long been a challenge for MHPSS programs. What we mean by this complex composite term. So it was both in some cases that people thought that PSS work just didn't really seem to be have an impact, and that people who were trained in the lower ends of the pyramid, can't really address mental health needs, or that the only type of MHPSS work that you can do is to be a psychologist and embed a psychologist into your work. So still continues to be misconceptions around what our work is across the movement. And so I think this is something we all need to continue to advocate, continue to educate our colleagues on, because it does continue to challenge our work and the integration of MHPSS. Another significant theme in the consultation was implementation of psychological first aid. I think as also shown through Ernest and Sarah's examples, is that psychological first aid is extremely widespread across the movement. It's been mainstreamed into the work of many national societies, and of course IFRC, and a significant amount of MHPSS work that happens across the movement is around adaptation of psychological first aid, adaptation of psychological first aid training from the PS Centre, for example, into different languages, into different approaches, adaptation of PFA for different cultural contexts. And so this is, I suppose the real message of this theme is we've really got behind PFA as a movement. It's really something that we've kind of gone all in on. However, many people also talked about it's not the full solution for MHPSS, of course. And while we champion it, as this quote says, there is also an issue when national societies in particular embed and approach psychological first aid skills, that then they realise they need more. Volunteers and staff need more than PFA skills. And that has become an issue for some national societies on how they then continue to build their mental health and psychosocial support technical skills, and at what point do they need to have stronger referral pathways to other organisations that can provide people in the community with more specialised services. And so, PFA isn't the full solution, of course, and that's, I think, was really clear across the consultation, and also to challenge the notion a little bit, to connect with the previous theme around misconceptions, that MHPSS is not itself PFA. It's part of a suite of tools and supports we have for people with mental health and psychosocial problems. Another theme was around the tools that exist within the movement, existing tools and how useful they were. So there was particular reference to the PS Centre's publication and manuals, and how many national societies and IFRC staff in particular use these in their work, how a lot of their work is around adapting these tools for their own contexts. But also, because we were a working group from the MHPSS Roadmap, many participants also referred to the Roadmap working group tools. The 5 working groups over the last 4 years have produced a lot of materials and resources, webinars, and many people kind of talked about the value of the resolution and the policy and setting direction of MHPSS, but also that the working groups themselves created a forum for people across the movement to come together and discuss challenges, issues, successes, and also in thematic ways. I mean, I think there are a number of, I'm just going to put that person on mute, sorry. There are a number of, oops, and I've managed to move my slides to. there are a number of forums, obviously, within the movement that are on MHPSS that are geographic in nature, but the working groups enabled people to talk on more technical and thematic thematic forums. So that was really valued by participants. There is, of course, whenever you develop global tools, many challenges that come with those, and that was also a key theme that came out of the consultation. And also, you know, I should add that very much the themes in themselves are recommendations, right? So things that we need to focus on addressing. So there's many challenges with the tools, accessibility, of course. So, you know, sometimes MHPSS tools can be highly technical and kind of full of jargon, and of course in the movement acronyms and all sorts of things. So they can kind of be a little bit inaccessible to people. Also language, there was a few comments in the consultation also around our reliance on written forms of communication. So, you know, people who might have visual disabilities are challenged to access some of our materials, and also accessibility around access to trainings and things in different, trainings being in certain geographic regions and associated kind of issues that come with that. Adaptation is also an issue, both language translation of tools that exist and that are developed globally, whether or not they're culturally relevant, and that the work that goes into adapting these materials, also the necessity of adapting things for local contexts, but that often national societies and IFRC need that kind of MHPSS technical skill in the adaptation also. And so there's some challenges there. And there was numerous comments around dissemination of tools that come out from global sources like the PS Centre, for example, or how we share tools between national societies, IFRC and ICRC, so that like dissemination of our technical output, I suppose you could say, is also challenged. And then the final theme was around the need for improved integration. And so, you know, and I think Sarah's point towards the end of, well, in her session, in her presentation, talking about that, you know, she really had buy-in from leadership, and that was crucial. And that really came out of the themes also, that, you know, there's in some cases recognition of the importance of integration of MHPSS, but, you know, the next thing is really that kind of buy-in, and that leaders need to walk the talk a little bit in relation to psychosocial well-being, and that it is a technical area that needs to be mainstreamed within all organisations within the movement to really fully enable integration. So those were kind of the themes that came out of the review, and as I mentioned, we also the way the report is, the themes are the recommendations. So we want to improve integration, we want to improve the challenges with tools, we want to, you know, really highlight that these barriers around human resourcing and financial resourcing are hindering our integration of MHPSS, and we hope that those can be addressed. So I will stop sharing, Monia, and I think with 3 minutes to go and me rapidly losing light in Sydney, just getting darker and darker as I talk to you, I will come back to you.
Thank you so much, Shona, for this overview of the key findings of the report. Yes, and I promise to you that there will be time for questions at the end. Now we've got 2 minutes left. I'm really sorry, I don't want this to be an empty promise. So if there's questions, please put them in the chat and we'll make sure to come back to you for your answers. Is there an urgent question that needs to be asked right now that can't wait? Does not seem to be the case. Oh, there's a comment, okay, that we can come back to later. But thank you so much for joining this webinar. the last one this year, but we'll make sure that there will be more webinars and possibilities and opportunities for exchange next year also. So with this, I'm concluding this webinar, and what remains for me to say is thank you to our three presenters. Thank you to Shona, Ernest, and Sarah for the rich insights. And to you all for participating. Please stay updated, sign in for our newsletter. I'll just put the link into the chat, and also have a look at the resources. I tried to link all the resources that were mentioned in the chat, and reach out to us if you need anything. It was really a pleasure having you all here, and I wish you a very nice day and night in your case, Shona.
Thanks, Monia, and thank you for being our fearless leader today.
Thank you so much for the opportunity.
Here is the
Thank
link.
you, Ernest. Thank you, Sarah.
Thank you, everyone.
Thank you.
Take care, everyone.
Thank you.
Bye. Thank you.
Also, we're also going to establish functional